Hi, my name's Andy Elliott. I'm an advanced clinical practitioner and I work as a locum in general practice. And I'm very grateful to ICG for the opportunity to have this discussion with Miriam, their chief nurse, about patient complaints to clinicians, and also about how some organisations are critical and maybe a little bit judgmental to clinicians who come into a new environment where they're going to be working. So I'm excited to be part of this discussion. It's very important to me.
Thanks, Andy. So as Andy said, I'm Miriam Palk. I'm the chief nurse for ICG Medical, a post I've held now for just over 11 years. And one of the things that I've been asked is, how do I think complaints have changed since COVID? And I think one of the things that is very obvious about complaints is, for people who are not permanent members of staff in an organisation, sometimes a complaint is made against them as agency workers or a locum worker and is more about communication, professionalism, and not so much about always clinical mistakes, clinical concerns, or different ways of wanting to do things. Pre-COVID, complaints were very much more clinically orientated, and there were more of them. Since COVID, I would say that I personally experience complaints which they're more personal. They're more of a discussion around an individual, their attitude, their behaviour, and not necessarily conducive to an open discussion about what's caused the concern. Complaints do reflect society. There's no doubt about that. And many agency staff, when a complaint is raised about them, will automatically make assumptions about it's because I'm a person of colour, or it's because I'm a male in a female-dominated profession, or it will have sometimes it will have a cultural event. So, I don't want to be looked after by this type of person or that type of person. So for me, complaints, they should be seen as an opportunity to learn. They should be seen as an opportunity to take on board what is said. The Nursing and Midwifery Council advise us to reflect when we get feedback, whether it's positive or negative. Unfortunately, my experience is that doesn't always carry itself across the organisations that are raising the complaint. And sometimes complaints are raised and responses go out to complainants, which will be along the lines of, oh, I'm really sorry, that was an agency nurse. They're not one of our staff, so we're not going to have them back, rather than actually looking at what the complaint was. And you do get ones where we'll get a complaint about an individual who wasn't even on duty. The date's wrong, or the rota's been changed and no one has actually checked the detail first. So for me, the trend in complaints is very much around attitude and behaviour. And I think around communication, professionalism, and unmet need, which I think is really difficult when wards and departments, whether they're GP practices, whether they're acute hospital wards, whether they're complex care settings, where maybe the needs of the individuals can't be met because there aren't sufficient people to be able to meet all of those care needs. So care has to be prioritised. So that's my experience of complaints over the last 10 years.
Yeah, and I think some of the complaints that I'm really interested in are what I call emotional and relationship-based complaints. And because of the nature of them being emotional and relationship-based and not on clinical incident, they're very difficult to prove or to substantiate because they happen behind closed doors. And I think whenever there's a complaint comes in, the health service has had a long and sad history of punitive actions against a complainant, against the person that is being complained about. And that's certainly been my experience. And I'm kind of wanting to look into how things can be done differently with an approach like restorative justice and restorative circles and restorative practice. So that's what's kind of encouraging me to air these concerns with people, because I feel that clinicians have suffered what was called post-traumatic stress or moral injury from not being supported and not being accompanied through a complaint process. And the focus is often punitive rather than looking underneath what's going on. And I often think the weight of empathy that's given to the patient is far greater than the empathy that needs to be given to the clinician in that complaint, especially when it's one of unmet need or unmet expectation, because it's not necessarily an issue with that person, it's an issue with the systems underneath it. And I think we need to kind of overhaul the complaints process and try and adopt a little bit more of a restorative approach. And I understand that's something that NHS England is looking into at the moment.
It is. And I think I agree with you. I mean, from an NMC point of view, we're asked to reflect. It's very hard to reflect on something which you believe is unjust, unfair, and that you're the victim rather than the complainant. And I think that next stage on, that being able to actually have those, whether they're mediated or whether they're discussions in general, is really important. Because one of the things that I find most frustrating as somebody who has to manage complaint processes is an organisation will contact me and say, we've had a complaint about this person, we don't want them back. Right? Well, can you give me the detail? No, we're just telling you we don't want them back. So I then have to go to somebody and say, Fred, I'm really sorry. I've had a complaint. The organisation has said you can't go back there, but they won't tell me why. And Fred may have absolutely no idea as to why he's been excluded. And so those are really, really difficult. And employers people who use agency and locum workers, some are really, really good. And they really treat those workers as if they are part of that organisation. And I've certainly had complaints, for example, where a trust has backed the nurse over the complainant, has worked to try and mediate in difficult circumstances. But they are a minority. The much more likely response is, well, actually, they're not our employees, so over to you, you deal with it. And that's really difficult for anybody who's on the receiving end of that.
I also find that when I go into a new place, it's very difficult. And I use a phrase that when I go into a new environment, it's like trying to dance without hearing the music, because you often don't get what I call a radical warm welcoming, where people welcome you, they ask a little bit about you, they're interested in you, they tell you how things work in their place, and they explain how the referral processes go. They make sure that you've got permissions to do blood tests, x-ray requests, and microbiology tests, do prescriptions. And a lot of the time I go in and I go into the room for the first time. On one occasion, somebody gave me a big folder, like a logbook, and said, there you go, you can start on that computer. And I didn't know how to log on. I didn't know what their systems were. And when I said I'll need some help to log on, I've got a little bit of an issue with dyspraxia when it comes to computers, the person looked at me like I was deficient in something and was really unhappy to help and wanted to brush me off. And I said, well, if you can't help me to log on, I'm not really going to be able to do my work. So it's really important somebody helps me. So I think from an induction and introduction, it's really important that organizations, if they're in need of staff, by the definition that they're in need, I guess they have a responsibility to make sure that that person that they're bringing into their organisation is as well prepared and fit for purpose as possible by a good introduction.
And I think that's really important because the same thing happens in multiple types of organizations. The lack of effective induction is ultimately what will later on trigger complaints and concerns. The standard, oh, so and so slow. Well, yeah, because you didn't actually take that first 20 minutes to actually ensure that they knew exactly what was expected. And in acute hospitals, it's even worse because actually the way one ward works may not be the same as how another ward works or another department. And so it is about understanding. For me, the most important thing about any clinical interaction that occurs is what you're trying to do is make sure that the person who's going to be providing that care has the knowledge, the skills, and the competency to be able to do that, understands the cultural scenarios that are occurring in that organization and in that particular ward, and so therefore is able to be part of that team as a whole so that things get done. And I think it's really important to understand that sometimes complaints come about because the behaviour of colleagues on a shift leads the patient to have a lack of confidence in an individual. Whether that's right or wrong, it's because they've learned that from what they've overheard and what they've seen from other colleagues on the ward. And I recently had a complaint, for example, where a patient was unsure if the registered nurse who was looking after him, who was one of my agency nurses, had the skills to be able to do that because he'd heard the healthcare assistant say she's only agency and so therefore she's not competent. And so we then have to go through a complaint. So because it's a complaint by a patient, the trust has a fixed process. It has to go through the NHS process. They have to write to me. They write to me apologising that they're having to send this complaint, but they need a response. I have to manage the nurse who's distraught that a healthcare assistant has questioned her ability to do her job. So we go through a whole process, and it could have all been avoided and was unnecessary for the amount of distress and stress it caused if the healthcare assistant had realised the impact of what she was alleging or what she was saying, that person could then have their own confidence knocked. So I think
that's indicative of society in general, because I hear people say he's just a locum, they're just a locum. And I know that when I'm doing my work, I work to the best of my ability. And sometimes I'm criticised for over investigating or over referring by the clinicians because I want to be as thorough as I can. And I know that when I leave that place, if there's any comeback, it'll be, it was a locum.
Mm-hmm.
And that's a really unfair and unjust way of dealing with locum.
And I think then the other thing that comes out from that is the fact that a complaint. So as I said earlier, the NHS has a complaints process and you have 28 days to respond, or you have to send a letter to the complainant explaining why you can't complete the investigation in 28 days. I've got complaints that have been opened I've got one that's been opened for 2.5 years because nobody will respond back to give an outcome. So what I do to give an end to the nurse, if after 12 weeks, so 3 months, I have not had an outcome from that complaint, I will close the complaint so that I can advise the nurse I've closed the complaint. The problem that gives is if the nurse, the locum, has been excluded by an organisation, be it a GP practice, be it a hospital ward, be it a complex care environment, I can't overturn that exclusion. I only have the authority to overturn exclusions that I put in place, not exclusions that other organisations put in place. So the nurse can't go back to that environment, even after they've sent their full statement, we've been through it, any learning that we've identified, they've maybe done the additional training that I've asked them to do, but you don't get an outcome. And that's where, for me, it's wrong. The nurse has a right to have an outcome, or the healthcare assistant has a right to have the outcome. It may not be the outcome that they want, but they have a right, and they should be respected and provided with that outcome. But unfortunately,
That's about
that's an issue.
closure. Yeah, that's
It
about
is.
closure and preventing what's called complaint legacy.
Mm.
Because I've been involved in complaints that are mostly emotional relationship-based complaints. And the first one, I'll just go through it. It was a long time ago, and it's a common theme that happens. And it was a mother of a child who presented with a viral illness. I explained that it seemed to me to be a viral illness and that it would last between 10 and 14 days maximum, and that the child should get better and didn't need any medication. The mother was so angry, she almost spat venom in my face. And I was really shocked and horrified because I was kind of new to this role. And I hadn't expected anybody would be like that to a healthcare professional. So I was probably a little bit naive. And I know that I dealt with the child professionally. I used guidelines, I used my knowledge and my education, and I did the right thing. And especially before COVID, we were very keen on antibiotic stewardship. When COVID came and people were being treated remotely, that meant that the floodgates opened again and we went 20 years back on antibiotic husbandry. So this patient was really unhappy that I hadn't prescribed antibiotics. So she complained to the duty doctor, who happened to be the senior partner, and it was about 5 o'clock. So, and I haven't got a problem with anybody wanting a second opinion. So the doctor said, well, go to the out of hours and do that referral. And I was told about the complaint, and I had no support, no acknowledgement of her behaviour towards me, no debrief, no accompaniment, no closure. And that mother, who was so unhappy with my consultation, that was a good consultation, she was advised to take the child to out of hours. And when I came back the next week, I looked, and the child hadn't been to out of hours on the Friday night, the Saturday, the Sunday. But on the Monday, the mother took her the child to A&E, and the child was discharged with a viral wheeze. So my consultation, my diagnosis proved correct. My notes were very good. And I'd even given the mum some information from Derbyshire Children's Hospital, which is called Two Peas in a Pod, and it's a podcast version of health advice. And the mother had actually criticised me for giving her a podcast that was of a good quality of information to try and allay her fears and anxieties about temperature. And all of that, it hurt so much. You know, it really did, because I don't think I know any clinician that came into the job to annoy people and not give good care, you know, and I had no support and no closure. And I carried that for a long time. And it's kind of what Sarah Payton, who is a nonviolent communication specialist, she would call that unaccompaniment. And when people are unaccompanied in a trauma, and these things are a trauma, it's recognized in the United States that repetitive injuries like this cause moral distress, which is a psychiatric condition.
Yeah.
And these things happen, and it shocks me that we kind of allow it to happen.
And I think it's really difficult as well, because sometimes when people receive a complaint, they get very angry about it. And then they do the worst possible thing, and that's they go and bury their head in the sand and think that, well, I'm not going to acknowledge it. I'm not going to do anything. I'm not going to write a statement. I'm just going to forget about it. And that becomes even more difficult from the perspective of trying to get closure in a complaint. And the NMC are very well aware that there is a higher number of cases raised against agency workers proportionate to overall complaints. And there's a rising number of complaints in relation to mental health workers as well. And some of that is because obviously there's much more visibility of mental health now. It was growing before COVID in terms of the recognition and the understanding that, mental health conditions anatomically are different from physical conditions, but actually they're the same. If you break your leg, you need the appropriate treatment, the appropriate intervention. If you have a psychiatric breakdown for whatever reason, you need the appropriate interventions, treatment. You need that, those need to be recognised. And sometimes when people have had complaints are raised against them, they become extremely defensive. And in that defensiveness, it can become very difficult to help them see what I call the wood for the trees. It's really difficult. I'm dealing with a case at the moment, for example, where an individual was excluded from a care environment on the grounds that it was alleged this person had written in the notes of a deceased patient, and it was alleged that he had or she had called the relatives. Following extensive investigation, I've been able to establish that the individual has no recollection of making any entry in the records. The ability to log onto the computer is via a generic login, so it doesn't track who made the entry. And because of the nature of the complaint at the beginning, it was a safeguarding issue. And so therefore, in line with our policies and procedures, that meant a temporary restriction from work whilst the investigation was undertaken. Now, the individual is quite rightly asking me to justify that decision that I made and saying, why couldn't he have been or she have been allowed to go and work in a different environment? Policies and procedures are in place to try and protect the wider community. And I have no problem with having to justify decisions that I make. And that would be the same if a complaint was raised against me. So, in terms of, I don't want to encourage people to raise a complaint against me, don't get me wrong, but, nobody should be above that answer. And it's a bit like, the NMC's approach to concerns is anybody can raise a concern to the Nursing and Midwifery Council. It doesn't have to just be through another professional. If a member of the public is dissatisfied with the actions of a nurse, they can raise a concern, and then the NMC have to go through a process of investigation. But complaints that generate NMC referrals are probably some of the most difficult and stressful for both the clinician and for those trying to support them, because they
it's
are
professional. It's professional reputation.
It is.
And it's income. People can't work.
Yeah. But it's also the other thing with it as well is you and I both know, Andy, that you work hard to get your nurse training, to get your registration in the first place. It's 3 years. Especially now it's a degree level program. It's a slog to get to that point. But it's even harder to retain your registration, to keep it up to date, to keep knowledgeable, to be able to use it. And there are so many potential pitfalls. And complaints are some of the most stressful environments. I don't think in the last 12 months, I don't think there's been a single complaint against a registered nurse where the first thing the nurse hasn't said to me is, am I going to lose my registration? Even some of the very simple issues that people worry that is going to be what happens to them. And fundamentally, it's because people care. I've always said to people, you don't come into nursing to become a millionaire in terms of pounds, shillings and pence, but you do become a nurse for the millions of experiences that you will have in providing care to those that you're privileged to look after. But, it's something that people people go into nursing and don't think, oh, people are going to complain about me. And I always say to people, we're not the angels. You know, whenever there's a press story about nurses, are angels this, are we're not angels. We're not devils either. We are like society as a whole. We fit into all different shades of colour and experience. And I think the thing for me is that that's what complaints are. Some are very personal, and some can be very vicious in the way that people are described or events are described. And as you said earlier, sometimes the clinician isn't given the same degree of respect or belief as the complainant.
And that's where I think the system falls down. And one of the things I've been reading into with this it's kind of been a quest over the last 2 years, really, is about restorative approaches and how that could impact on complaints. And I was speaking to a man from the Restorative Justice Council, and he's done some work with national health organisations, and it was about internal conflict within an organisation. So people complaining about the people they were working with, and it was going round, and it ended up costing that organisation hundreds of thousands of pounds in redeploying people being off sick and all sorts, when he went in and did a restorative approach to what was going on. And that took 3 days, which sounds a long time, but when compared to hundreds of thousands of pounds, and I don't think you can always quantify these things by pounds, shillings, and pence, like you said, because it's about the quality of the service that people are offered and the humanism that we're supposed to show to each other as a community. And that's something that I think's been lost in the last decade for sure.
And I think the other thing that's really interesting that goes along with that as well is there was a report done it reported last year, but it was done the year before. And it was about the engagement with temporary workers, be they agency, be they bank, be they locums, be they whatever, when there was a serious untoward investigation, because invariably they weren't involved in that process. But they may have the critical evidence in that serious untoward investigation, which could have a huge impact on future safety of other patients. Yeah. And I think, there's lots of elements around that. But the other thing that I was going to say in relation to what you were saying about restorative activity and, people complaining about people, I'll often have a nurse who'll say, I'm not working on X ward. I don't like it there. Why don't you like it there? They're not very nice to me. Well, what are you like to them? What do you mean? What am I like to them? Well, do you smile? Do you engage with them? What? Well, I'm only there for the shift. So you have a mirror reaction to your behavior with them. You need to change. You need to make a small change so that it may be that actually, instead of always looking down, you actually look at somebody. Look somebody in the face when you're talking to them. Don't look at the laptop. And I'm a great believer, for example, in picking up the phone and talking to somebody than I am sending them an email. Because if I send them an email, they're going to send me another one, and that means I've got to answer that one, and it's like an ongoing chain. And I think that it's really quite interesting because one of the things that's happening at the moment, because there is less agency work in acute settings, many agency nurses are applying to join banks. And so an agency nurse has had a horrible complaint from a particular trust. But oddly enough, she's banned as an agency worker, but they'll take her as a bank worker. So there are some other anomalies, shall we say, in how things get handled. And I think the other thing as well is it's not helped when big public organisations. So, for example, recently the GMC has been very critical of advanced nurse practitioners, and they're being used to replace doctors. No, they're not. They're not doctors. They're using their skills to supplement a limited medical resource. And I think that those sorts of public debates can lead to a lack of confidence, as I indicated earlier, when a patient sees a advanced nurse practitioner and not a doctor. And I asked for permission to be able to use this example. My brother-in-law has been quite ill, and he's had to have some surgery on his arteries, his leg. And my sister phoned me and she said, "Flipping surgery?" I said, "What are you moaning about?" She said, "Oh, I've got an appointment to take her husband to the surgery." I said, "Well, that's good for his checkup." "Yeah, but it's not with the doctor." I said, "Who's it with then?" "Oh, it's with something called an AMP. I said, "Well, that's an advanced nurse practitioner." "Oh, well, are they qualified to do that?" I said, "Ange, they're probably more qualified to do that part of the package of care that your husband needs than the GP is." I said, "How long's your appointment with the AMP?" She said, 15 minutes. I said, "You'd have had a 5-minute appointment with the doctor." I said, "So." And then when she'd come back, she said, "I'm really glad we saw that advanced nurse practitioner." She stopped using the abbreviation and recognized the professional knowledge of the individual that she met. And I said to her, "Well, that's really good. I'm glad you were." Yeah, she said, "I'm going to write a letter." I said, "Oh, yeah, what are you writing a letter about?" She said, "I'm going to write a letter of compliment." She said, "Because all you ever do is write letters of complaint." I said, "You get on with it and you do that." And I think that's the thing. We're very quick to complain. We all do it in life. You know, whether you're complaining about poor service with your home shopping, whether it's how your football team are we all complain. We don't always think, "Do you know what? They did really something happened and they did really well, and I'm going to say thank you, and I'm going to acknowledge that they did that really well." And I think that's where we've moved away. It shouldn't be that I have to write to somebody and say, "I've had this lovely email from whoever at the trust. They've asked me to share it with you. I'm really delighted to be able to share this, as this is such a rare occurrence." I shouldn't have to write that. I should be sending those letters out as frequently as I send out complaint letters, but I'm not. And that I think is sad. I think that's really sad.
I 100% agree with that. I think there was, at the turn of the 2000s, somebody called Horrocks was writing about people being dissatisfied by seeing non-doctors in the general practice, and people dealing with kind of medical issues goes back to the 1960s with the original nurse practitioners in the London suburbs, because there weren't enough doctors there. So it's not really that new. It's just people's perception of second best. And I certainly know I've had lots and lots of really positive comments from people, and I put them in my portfolio. And I'm frequently never told about them by the GP practices where I work. There's no engagement in that process with me as a locum, which is quite sad.
And it's really interesting because I've just recently had a report, or had shared with me an audit report that a practice had done on the care that had been delivered by GPs, AMPs, pharmacists within their surgery, and it will be for their CQC recognition. But they sent it to me because the highest audit results were from the 2 AMPs who work for one of the brands owned by ICG. They had the highest audit reports for that particular surgery, and they were being held up as really good examples of people that cared not just about their patient, but about their documentation. Because at the end of the day, if our documentation is substandard, then that enables people to believe that the care that they've received is substandard. And I think, you know, we as practitioners have to remember that our documentation isn't about tick boxes. It's about explaining what we've done. I mean, the NMC always say, don't they, if it's not documented, it didn't happen. And I think, you know, those sorts of things are really important. And often with complaints, as I said, attitude and behaviour is the biggest issue. And the use of computer systems helps to prove that boxes get ticked. But ticking a box to say that you gave 10 o'clock medication is not the same as saying, I gave that medication at 10 o'clock, but the patient really struggled with the size of the pill that they had to have because it's like a horse pill rather than they need a liquid or they're better with capsules. So I think it's just also remembering that when complaints come in and when we have to look at our practice, we need to look at it and see what other learning can we take from that.
Mm.
I think that's the bit that's really important to me. And I always tell everybody, complaints happen by the very nature that we are human beings. We learn from mistakes.
Mm.
So for me, if somebody makes a mistake and they can learn from it, that doesn't make it a crime. But absolutely, it becomes a crime for me if they repeat exactly the same mistake because they didn't learn from it first time round.
Mm.
And I think that that's something that nurses almost they deal with the complaint, deal with the incident, and put it aside, but they don't continue to learn from it and they don't remember the learning. And that's something that it's my job to help our staff to understand that.
Yeah.
And to understand the importance of recognizing and not making those mistakes again. Because, we all say the same. I'm not the only one that says it. At the end of the day, we want care to be delivered to a level which is acceptable to you, to me, for my family, for my friends. That's the level of care I want. I want
Mm.
a Rolls-Royce level of care. Realistically, the NHS can't afford everybody to have a Rolls-Royce level of care, but it certainly needs a standard of care which is safe and is appropriately delivered, and that the staff who are giving that care, whoever they are supported and enabled to give that care.
Mm.
Within the NMC code, it is absolutely clear whoever is managing a nurse, be it for a shift, be it for a span of locum duty, whatever it is, has a duty to ensure that that individual has the knowledge and skills and the competency to perform the role that they're being asked to perform and are supported to complete the NMC code requirements. So it's not good enough for a ward manager but it's not good enough for a ward manager to say, oh, this nurse was too slow, too rubbish, whatever,
Mm.
and then say, we don't want them. And you go back and you say, well, how many nurses were on duty? What was the induction? What was this? What was that? If you, as the nurse that's in charge of that span of duty, whether it's a day shift, a night shift, whether it's a locum shift, you have a duty to support that individual. And that's Section 25 of the NMC code.
So that bit about support, I'd like to go back to that again, because this is kind of the really important thing for me. And earlier we talked about the nuances of complaints and the different things that impacted on them. And I've always seen that complaints, when they come, you end up feeling like you've got a black mark against you and it's really quite heavy. And often they don't feel fair or justified. And one of the things in context that happened is I was on the phone to a lady. I was asked to do a telephone consultation with her about a specific thing, and she went off on a tangent. Now, some people would say let the patient go on, and then when they finish saying what they want to say, but sometimes in a time limited period, it's difficult to do that. And certainly as a locum, you don't know people, and when you're doing it on the phone, you can't see faces.
Yeah.
So the lady was going off track from what I was supposed to be discussing with her, and I could feel that she was getting a bit niggled because I was trying to shepherd her back to what I needed to deal with. And it ended up me recognizing and feeling scared that this consultation was going to slip off the plate and be a bit of a road crash. And I said to her, can we just stop there for a second? Pause, the first thing to do with any conflict, pause. It's very difficult to do a consultation like this because you can't see me, I can't see you, and we don't know each other, and I don't know anything about your background. So can we please try and start again? So I tried that, and it kind of worked, and I recognized that she felt uncomfortable. as much as I felt uncomfortable when you're a clinician, you get 80% of your diagnosis from a good history. So it's really important to make sure your history, you get the information that you need. So there was a complaint came in from the husband because obviously, well, not obviously, but the lady cried afterwards, apparently, and was very upset. And in the complaint, he'd not heard what was being said, but he said he didn't appreciate my attitude. But that statement was based on looking at his wife being unhappy, which was an interpretation. And he said that on top of that, she was so frustrated because she's not been able to get an appointment for 3 weeks. And she's also in a lot of pain. So with that consultation and the simple communication that was going on top of that, there were 2 layers of her pain and her frustration, which contributed to the complaint. And it was looked at uncontextually, and I felt blamed that it was down to me. And it kind of, I know sometimes I can get things not going as I would want them to, and I can always learn from them. But that was a pretty standard sort of consultation where I needed to get the information to do what was requested of me on that particular task. And I think when you get complaints in context, it's really important to understand the context and the other triggers. We talked about more complaints, and it's because the world is more stressed with things happening in Israel, the Ukraine, Donald Trump. All of those things are creating world stress. People have got stress in their lives, in their jobs, and the economy. So there's a lot going on.
And I think the other thing for me, not even taking it, not undermining what you've just said about the worldwide stresses that people are under, but people's lives in general. When people go to work, they often don't share important information as locum workers because they don't know people. So, for example, I always tell our teams, if you notice a change in one of your nurses, can you let me know whether they've always been really quite happy and bubbly, and now suddenly they're not communicating as well, because there may be something going on that they're not able to talk to you about, but they might be willing to talk to me. And that happened not that long ago following a complaint. And the booking officer sent me the complaint over and said, we've never had any complaints about this particular individual. She's normally not a difficult worker or anything like that. So when I phoned the worker, because my process is always to phone an individual before I send them the email. If I can't get hold of them, then I have no choice but to send the email about the complaint first. And when I managed to get hold of the nurse to speak to her, her husband had been diagnosed with stage 4 prostate cancer. Her mother had had a stroke, and she'd found a lump. But she was the only one that was working. And so she burst into tears on me and said, I can't deal with this complaint. I can't deal with this. I can't. I said, look, you're not going to deal with it as it is at the moment. I said, the first thing you're going to do is make an appointment, because you are going to get that lump looked at, because it might not be anything that you need to be afraid of. And I'm going to start the process of managing the complaint. Anyway, managed to get that all sorted, and she went, and it did turn out that it wasn't a lump that she needed to be worried about. But the attitude and behaviour issue that had arisen in the trust on this particular shift was because of this background information which they were unaware of. And it wasn't a massive behaviour issue. It was just 6 of one and half a dozen of the other, I suppose, is how I would describe it. But because we were able to explain to the trust with her permission what had happened, they were immensely supportive. The ward manager, when she was told what had happened, said she was going to withdraw the complaint. And we said, well, you can't withdraw the complaint because it was a poor response to a colleague. But, we need to just work through what she's dealing with at the moment, and then we'll come back to it. And the trusts were brilliant with her. They couldn't have been better with her and with the situation. But when I spoke to the booking team about it and said, so how long have you noticed this change in this person? They said, oh, about 3 weeks, but they hadn't told anybody. So we could have preempted this. But as I say, I think the thing for me is locum and agency workers, there's a limit to what they feel comfortable to share with people that they don't know. Because after all, when you join a ward as a permanent member of staff, or you join a practice as their practice nurse or whatever, you're joining a team that you're going to be working with long term. That's what you would hope. And so your relationship builds up over time. You can't just suddenly walk into an organization and become the best friend of everybody in the organization in the first hour that you're there. It takes time. But the thing for me is ensuring that our nurses are prepared for whatever environment they're going into, that they are given the information about the handover. I mean, some trusts, for example, now they'll give out they have a training thing for the electronic patient record. So there'll be a link and the nurse has to do that before they arrive on duty, which is a bit of an inconvenience because actually that's their own time, but most of them don't mind and they do. It's 1 or 2 trusts will pay for an hour extra for the nurse to be able to do that, but not everybody. But the preparation for people to go in is really important. But the other thing that's really important for me is if an individual has had a poor experience, don't wait for the complaint to come in. Tell me about it up front, because I may be able to preempt it never coming in as a complaint. Or it's not the right phraseology, but we get the nurse's account of her poor experience to the trust before the ward sends its complaint to them, so that there's a better parity in what's going on. But agency workers, as a general rule, don't want to raise their head above the parapet because work is so difficult for them to get at the moment, especially for the acute areas. They don't want to run the risk that they'll get stopped from working. So they take on board and they internalize more than most substantive nurses would.
Communication in general is a really complex thing, because I've worked in A&E for many years, and sometimes in stressful situations, people are very snappy or very sometimes rude and sometimes very critical, and harsh words are said. But it was always never taken any further because people understood that was the kind of environment that people were working in, and people were given some slack for that. But I don't think we give each other slack. And like you said with that lady with the lump and the partner with stage 4 prostate cancer, I always try and think about, don't greet somebody the same way today as you greeted them yesterday, because a lot could have happened in the last 24 hours. And we don't show any curiosity. And what you said about asking, is everything okay? Because a lot has been talked about mental health support and mental health awareness. By it's okay in situations to say, are you okay? And that "are you okay" can open the gateway to somebody explaining something that's difficult for them, and then the gateway to a process of getting the right help.
And I think that's really important. And I think, as I said earlier, people will talk to different people for different reasons. And I think that's really important to recognize. And I think that sharing an experience, so like my sister's experience with her permission, it's really important sometimes to be able to humanize. And one of the things that I often say to people is, when I first joined ICG in June of 2015, it was a very different company to what it is now. It was tiny in comparison to what it is now. I mean, it's an international organization now. And so I was dealing with complaints, and I had a set process of going through, very much mirrored on my previous role from the NHS and how I dealt with complaints through that. And I would let people know. And I had a phone call from a nurse. I'd sent her a complaint that had come in. It was about her attitude and her behaviour when she was on duty at a London trust. And I took a phone call from this nurse. She ranted and raved at me, and she was so angry. She was spitting feathers, basically. How dare I decide that she was guilty of this complaint? And I said to her, but I haven't. I've just told you what's been said and asked you for your account. Your email makes it sound like I'm the one at fault. Okay, says I. Right. Okay. Well, I'm sorry if that's the perception that you've got. That was not my intended perception, and I'll relook at it. So I went after I'd calmed her down and told her what I needed her to do. And all the time I'm thinking, her attitude and behavior was what they were complaining about. Her attitude and behavior towards me on that phone call was not acceptable, but I wasn't going to challenge it at that point. And I went back and I looked at the email, and I realized that in the email that I was sending out with the complaints, I wasn't acknowledging that at the time that I was writing to them, all I'd got was the trust account or the community services account or whatever the organisation was. I'd only got their account. And it was really important that the nurse was enabled to give her account and for her voice to be heard. So I changed the wording of the email that I used, and it's still the same sort of email. And then the other thing that I did was I changed the process. So instead of phoning them after I'd emailed them, I phone people, or I attempt to phone people before I send the email. But it was quite an interesting response that I got from this lady. But when I reflected on it, there was validity in what she was saying. The way she said it and the behaviour that she exhibited was unacceptable. And so after we dealt with the complaint, I gave her constructive feedback on how I'd experienced her. She said, well, I was angry. I said, I know you were angry. I said, but you didn't need to use the type of language that you used when you were talking to me. Don't do it again, because if you do, I'll eat you up and spit you out. Because it's for me, the insight that she gave from her experience of receiving my communication 11 years ago has changed how I communicate about complaints. And I don't always get it right, because complaints are very personal. I don't get it right. Not every time. I try to, and I try to do the best that I can to ensure that those that are involved in complaints are supported. But it's really difficult, as I said earlier, when trusts don't respond and they don't give me the ability. And as far as the nurse is concerned, I'm not doing enough because I've not got this resolved for her or him. But there is a limit as to what I can do. And I have a group that I chair of people in similar roles to mine with ICG. And we all have the same experience, that the worker wants the resolution. The worker wants the apology. They're not wrong. The trust is wrong, or the client is wrong, or whoever is wrong, but they're not wrong. They want that. And those are the ones that are the hardest to resolve, because that person's not necessarily recognizing their part in that process.
Well, that's part of the restorative process,
Yeah,
isn't it? It's both people recognizing and listening and having the capacity to hear and the ability to not react and to respond in a way that is conducive to both sides learning.
And the difficulty with the restorative justice approach, however you look at it, it is totally dependent on the engagement of both parties.
Yeah.
And it also has to be recognized that if both parties aren't engaged in it, it can be even more damaging. So it's really about finding the right approach that works for the right individual. I'm a huge advocate of restorative learning and restorative circles and restorative justice in general. And obviously restorative justice in the criminal arena has helped to bring that more to the fore, with the idea that victims get to meet the perpetrators of crime. And there are shared stories, and that helps people to understand that it's actually okay to do that. I think obviously I deal with complaints across multitudes of settings, not just clinical practice, GP practice type environments. But I think that there are some fundamental principles about complaints. The first thing is the complainant needs to make sure that they've got their facts before they make their complaint. So that the person who is on duty, that the person that they're complaining about actually was on duty. And the person that was involved in that particular case was actually involved in that case. Because I've recently had one with a 24-hour service, an out-of-hours service, where it was alleged that the AMP hadn't gone to a visit. Well, she hadn't gone to a visit because she was actually on a different side of the county, and it was supposed to be a doctor that should have gone to the visit that didn't get the visit. So it's about facts, making sure that facts are correct. That's the first thing. The second thing is how the complaint is structured and how it's shared with the individual. So, for example, I can't support somebody if we had an example this week, a GP surgery has sent a password protected document and won't send us the password. They want that forwarded on to the ANP and for the ANP to then contact them for the password. So I have no idea what that complaint is about. I can't prepare the individual. I can't support the individual to understand what they might find when they open that document. That's wrong. Because actually, I am the employer of that individual, for want of a better phrase. So I think openness and shared experience is important. And I think timely responses is also important, both from the clinician and from the trust or the organisation where the complaint has occurred. And I think that particularly for the roles with the AMPs, for example, sometimes things have to be done which are slightly outside of protocol due to an emerging situation. And I think that there needs to be a recognition from practices about the rigidity of some policies and procedures. I'm not saying that all policies and procedures shouldn't be rigid, because many of them should, but there is that grey area, and policies don't always have built into them a secondary protocol that allows a secondary action. So you have to then go back through a whole new process. And it's a particular issue for the 24-hour services, the out-of-hours services, where an ambulance organisation will send a request for an AMP to go and do a visit, but won't send all the information. And when the AMP gets there, it's a slightly different scenario, like it's actually end of life, but nobody gave them the information and there's no access to records. So I think that there's how the complaint is formalised and sent through is really quite important. And then the one that drives me absolutely potty is when somebody says, we want a response within 24 hours. Sorry, no. An individual needs time to reflect on, depending on the emergency of the situation. If it's a highly critical safeguarding concern that needs a quick response, well, that's slightly different. A draft response can be sent, but you don't give somebody 24 hours to provide a response. Not unless you want a very unhappy chief nurse writing to you and saying that you will not be provided with that response in this time frame, as it's unreasonable. And I'm happy to make the complaint to whoever needs to have that complaint made to them. It's generally, for a red response, I would expect a response, an initial response to me, at least 24 to 48 hours, as in 1 to 2 working days. An amber response, that's 5 working days. And a green response would be 7 working days. And I RAG rate our complaints so that we know what we're working with. And I think the other end of that is the clinician has to be responsive. I'm still waiting for a clinician to send me a response to a red alert that happened last week. And they're a little bit upset that I've stopped them from working, because I can't value judge and risk judge the situation without their account. So I think for me, honesty in the complaint, speed to try and resolve the issue for everybody concerned, not just for one party, and also the importance of sharing that learning. One of the things that I'm really keen about is if we identify an issue in an organisation, then I want everybody that works in that organisation to know that that's potential risk and that they need to be mindful of that event. So, for example, we've recently had a trust who have said agency nurses must be flexible. They must agree to go to A&E and work basically as a pair of hands, band 5 pair of hands. They're not A&E nurses. And if they won't, then please don't send them because of having to flex the staff through. So it's about sharing that and sharing that forward. So for me, it's about the learning cycle.
Yeah, I think that's important about learning. And sometimes when a situation occurs and people don't learn from it and the information's not shared, or the underlying problem that caused the issue in the first place is not addressed, it's like letting something out of your net. You capture something that's valuable and that you can use to make things better. But if you don't tie it off and share it with people, then it gets lost. It evaporates like ether. Yeah.
And then the mistakes will continue.
Yeah, yeah. And that's unfortunately the NHS was called a non-learning organisation by a fellow called Seng from I think it was MIT many years ago. And I certainly see organisations that demonstrate a behaviour of non-learning and not being open to learning and not being curious, thinking that the way they do things is the only way to do them. So I guess for me, when it comes to complaints, I'm focusing really on what I call the emotional and relationship-based complaints that make up 66% of GP complaints in general practice. And they're about communication and perception. So they're not fact. So because they're not fact and very difficult to be proven, I think there needs to be an openness to listen to both sides. And I think when I've received some complaints, they come to me as an email. And like you say, that's it's not very personal. It doesn't give somebody the opportunity to say, look, Andy, I know you're really good at what you do, and we've got this complaint, and I'm sure it upset you, but we just need to go through it. It gives you a little bit of reassurance that there's a human being considering me. That's the first thing. And to feel supported by the organization through that process I would like to have the opportunity to have a restorative discussion with the complainant. And that's a difficult ask because when I was talking to somebody from restorative justice, I think somebody that has those skills, you wouldn't find in many hospital trusts or many GP surgeries. And that's why a lot of these people that do restorative justice and restorative practice training, they run their own courses. But what some NHS trusts ask is them to train somebody to be a trainer. And I think you lose a lot of the concentration and the dilution of that person's skill and the ability to hold a space where people can have a dialogue. And when it comes to some of the issues about antibiotics for viral illnesses, or wanting an X-ray for a bad back, or a referral to this consultant for whatever, I think there is an educative process that needs to be taken responsibility for by the organisation to share with the complainant that this is evidence-based practice, that the majority of sore throats are viral, they get better on their own. And it's a process of education, and that's part of health education. That's part of my role when I see people. And sometimes it's very difficult because people have very fixed attitudes to health belief systems. So it's very difficult to unstick those. But I think if you don't go through that process, which may take a short amount of time, it's going to build on the foundation for repeat behaviors of people expecting different things. And the one thing that's really sad for me is, and this often happens, and I've talked to many other ACPs about it, is that when you decline antibiotics and explain the reason, they get an appointment with the GP, and then they get the antibiotics. So
Not
even though,
because it's what treatment requires, it's because it's
no,
easier to get them out the door.
yeah, and that's part of, in a survey, there were 90% of GPs feel they've been bullied or coerced by patients into doing things that they don't think are clinically indicated. And that's kind of not good for clinicians to do that, because they're not working ethically. They're not working as they trained to be. And it's not good for confidence. And it's not good for patients, because they learn, if they shout the loudest, that they get what they want, and that's not a good thing. And it's not good for society, because it utilizes more resources for that could be spared for somebody else. So, and patients often don't realize that the issue with antibiotics is that it reduces your ability to fight disease next time it comes, and that it will destroy some of your gut bacteria, and that will have an impact on you in later life. So I think, from my perspective, as well as restorative work, sometimes uh, these scenarios need some explanation from a third person. And I'll just go back to the first patient that I talked about, the complaint, the lady with the son who had a viral illness. What I would have really wanted and valued from that was that the senior GP sat down with her and with me and said, and this is before or after restorative justice, something along the lines of, I can see that Andy's notes are very clear. He did a very good comprehensive assessment. His diagnosis seemed reasonable, and not giving antibiotics was the right thing to do because XYZ. And he also gave you a podcast to listen to from the Children's Hospital in Derbyshire, Two Peds in a Pod. I've actually not heard of that before, and I'm going to start using that in my practice. And that kind of support would have made an awful lot of difference to me. And the last thing is closure, and not feeling that you've got black marks and professional slurs totting up against you, when people might then decide, we don't want you to come back. Because if you exclude somebody from working who's working well, but there are issues that are not particularly with that person, then you're reducing your ability to provide the service that you need to provide. You're reducing the pool of workers if you exclude people.
And that is important. But I think at the end of the day as well, the thing that impacts most on complaints is the humanistic approach to things, is that we are all humans. And so the way that we perceive things, our expectations, what we want culturally, what we've learned, all have an impact on how we respond to events and challenges. And, in an ideal world, I'd love to think that everybody would be willing to engage in that approach of sitting down and having that conversation, that open adult conversation with people. And there has been some improvement towards that, but there's a long way to go before people start feeling so injured by what they see as unfair and unjust complaints.
Yeah.
We do have to recognise that some complaints are just and they are fair.
100%. And people can also learn from them. And there are some things that are done that shouldn't be done. And that's quite clear. But I think my focus is on the complaints that are emotional and relationship based.
And it's much easier when you've got facts that you can hang a hook on and say, right, factually this happened, factually that happened. But as you say, when it's emotion and when it involves perception, it becomes much more difficult.
So I guess that there's a lot of learning, and I'm really happy that we've had the chance to have this conversation, because I hope that it will reach an audience that it can have an impact on, to promote discussion and debate, and maybe is the first part of change. So that's something that
change has to begin somewhere.
Yeah, for sure. So thank you very much.
Thank you, Andy.